Hello, welcome all. I am very glad that we are together today, October 9th, in the webinar of, there is one colleague of, make your microphone unmute, please. Mute, please. Yes. We speak together for 2-3 minutes till we start. And as you know, this is the second ASCO-GOIS International Webinar. ASCO, as you know, is American Society of Clinical Oncology. GOIS is Global Oncology-Implementing Science program of the GOU. The objective of all this series is to make together scientific stimulation and brainstorming on how to increase affordability of better value cancer care via scientific approaches. It is very crucial issue. And this is our role, I think, as doctors, as scientists, as researchers, as students in science, cancer care professionals. And it's not to complain all the time of the increased gap and to speak about programs and plan and commissions that failed along or over the last 2 decades to decrease the gap. This is a fact. And there is no convincing evidence that there will be change in the future. So we are trying together to stimulate and to make a movement of collaboration and cooperation focused on one object to increase affordability of better value cancer care. Is not to speak about the stereotype speaking about cancer control and about the tragedy and about the advanced cases, about inequality, about disparities. No, how to lessen the disparities and how to deal with the equality as doctors, as scientists, as pharmacologists, as physicists, as chemists, via science. This is our job, not to complain like others. This is not our job at all to the public health talk or TV talks. Now, I think we can start now. And I see a list of very dear colleagues with us. And I see also from ASCO, Jessica Williams and Sarah Bashman. Thank you very much for this cooperation together. And we'll start with the introductory note of Professor Robinson, the president of ASCO 2024-2025. And I would like to say a last notice before the record that our webinars is not counting on the audience on the live discussion, but on what we record together, and there is work after the reporting. All this you return back to all of us to have to have reporting and to follow up. Is not just webinars and goodbye, but the full records will be sent to all and sent to many, share with all. It is part of movement, not just webinar and goodbye. There are a lot of webinars everywhere in the world. If you click now, you'll find many webinars in the world. But it is a solid start of a scientific way together. We don't claim that we do all, but just stimulating and presenting approaches. And our success depends on all of you and all our colleagues and collaboration with many in the world. Please, everyone, is advocate, is the messenger for this. Thank you. And now I have the honor to present Professor Robinson.
Greetings from Niles, Michigan. I'm Robin Zahn, President of the American Society of Clinical Oncology. Today, I am pleased to welcome you to the second installment of the ASCO-GOIS webinar series. As an international organization, ASCO is proud to have over 50,000 members in more than 170 countries. Given our own commitment to global impact, it is only natural that ASCO would find such an ideal partner in SEMCO. Since its founding in 2002, the South and Eastern Mediterranean College of Oncology, or SEMCO, has been an impressive champion of professional development and education for both oncology professionals and the public across not only the Mediterranean, but the world. SEMCO has served the global oncology community as a facilitator of collaboration and cooperation between regional and international organizations and societies, including ASCO. This year, it is our great pleasure to partner with SEMCO on the ASCO Global Oncology-Implementing Science, or GOIS, webinar series, a complement of virtual education sessions designed to inform cancer care professionals of hot topics in global oncology and explore the scientific and patient-centered approaches to finding and validating accessible and affordable therapies. The goals of this series will be met through a variety of short presentations and panel discussions with international experts during each session. The first webinar in the series, Improving Access to Global Oncology Care Through Repurposing, was a great success, prompting new and interesting discussions on the idea of repurposing oncology medications. Today's webinar will address the myriad issues surrounding implementation of the science of global oncology. We hope that you will find the presentations informative and the panel discussions engaging. Finally, I would like to take this opportunity to thank Dr. Ahmed Elzawawy for his hard work and dedication to this webinar series. Dr. Elzawawy is, among many things, the co-founder and co-president of SEMCO, chair of the Win-Win Initiative, and president and founder of iStock. I and all of us at ASCO thank all those involved in the creation and implementation of this wonderful and very important series. We look forward to future sessions and the discussions as they advance. Thank you and enjoy this webinar.
Deepest gratitude really to Professor Robinson and to ASCO. And with the leadership of ASCO and all leadership in the world, we can go forward. Next, with Professor David Kerr. As you know, Professor David Kerr is one of the main leaders, a co-founder from the start of the Win-Win and our Global Oncology-Implementing Science. And with his leadership, we are going forward. And he's also the immediate past president of ASCO International Affairs, as it is these webinars of ASCO. So I am very honored to present Professor David Kerr, with many, many titles, by the way, Professor David Kerr.
Hello, I'm David Kerr, Professor of Cancer Medicine at University of Oxford. And of course, I'm delighted to be taking part and I hope welcoming you to this second in our webinar series in which ASCO and our Global Oncology-Implementing Science group, led by my dear friend, Professor Ahmed Elzawawy, have come together to see what we can do to work with you, with our audience, hopefully of young oncologists, to see what we can do to deliver better value cancer care. There's no doubt that our community does need to come together to see what we can do to reduce the equity gap between the haves and have-nots, the patients that all of us serve to seek to care for. The theme that will run through all of our webinars is how can we do better with the drugs, the agents, the radiotherapy that we have? How can we use underpinning science, or understanding of clinical pharmacology, molecular pharmacology, the radiation biology, to develop cancer treatments which are safe and efficacious, but also cost-effective. One of the things we'll talk a little about today is optimizing dose, and how we do that. Simple things like flat dosing, using single vials rather than dosing according to body surface area and wasting drug, using pharmacological principles to guide us to the right dose, with work from Ian Tannock and Mark Brattain suggesting we could save tens of millions, even possibly hundreds of millions of dollars by dosing better, by interpreting phase 1 and phase 2 clinical trials more appropriately. Great to welcome you. I do hope you enjoy the webinar. Always we're looking for contributors for new ideas, and anything that you would like to post or tell us about, we'd be very, very keen to understand. So thanks very much for coming with us. And again, many words of warm welcome from the Dreaming Spires of Oxford. Thank you.
Thank you very much, Professor David Kerr. And for all audience, please stay with us after the panelist, and we to discuss and to send your note. And also, after we receive your feedback, your idea, your even criticism, your comments, it is your own endeavor. As we say that there is a reporting for this meeting, plus the plus the recording that you all have the copy, I am glad to introduce to you my colleague, Professor Abba Mallum, Associate Professor of Radiation Oncology in South Africa. And he is one of the really very active and dynamo in the field of global oncology. He is the rapporteur of this session. And also, what is important is the work after to translate this into continuous movement. So please, my colleague, Professor Abba, introduce yourself, and thank you for all what you do and what you will do.
Thank you. Good afternoon, esteemed colleagues and members of the panelists, my mentors and attendees of this important series of ASCO-GOIS series. I am Abba Mallum, an associate professor in radiation oncologist based in South Africa. I will be serving as a rapporteur of this series, and on that course, I am highly honored to serve in that position, and I will going to make all the work at the ends to just record everything and share it across to get an outcome of it. Thank you for the opportunity. Prof. Ahmed Elzawawy, once again, thank you. I will be looking forward to learn from the expert and also to assist, to facilitate where I can. And thank you for allowing me being part of this valuable conversation. Thank you, Prof. Elzawawy, once again.
Thank you, my colleague, Professor Abba Mallum. And now, excuse me that I'll present myself now as not myself, but it is overview of the whole thing. This webinar today is notions and needs for global oncology implementing science to increase affordability of better value cancer care, global cancer care. This introductory overview, and I added here a note about also Optimus project. It is updated from a Global Health Catalyst Summit in June at Johns Hopkins. I am Ahmed Elzawawy. Ahmed Elzawawy, chair of Win-Win Initiative, chair of board of directors of Global Oncology University, the GOIU, founder and president of ISODOC, international campaign of establishment and development of oncology centers, past president of Aortic African Organization for Research and Training in Cancer, professor of clinical oncology, Suez Canal University, and chairman of Al Suleiman Radiation and Clinical Oncology Center, Port Said, Egypt. And here is my email. Disclosure of conflict, none. But this presentation is on behalf of all leaders, faculty, and the Win-Win Initiative. And I inspire from the work and the discussion with distinguished colleagues, international organizations, and society in the world. Also, it is after personal discussion over years with leaders from health industry, major pharmaceuticals, and radiotherapy companies, Varian, Electa, for example. Particularly, I acknowledge the precious and very valuable advices over years till present of Mr. Dow Wilson, past president and CEO of Varian Medical Systems. But there is no any financial support of any kind. I am completely independent. Some brainstorming notes. What is global oncology? Reasons for this question is sometimes there is a confusion between science of global oncology, it is a science, global oncology, and the general public health topics, advocacy, and public talks about cancer. Even it becomes sometimes business, political talks, slogan. Although public health and cancer advocacy are mandatory and very important, but it's not necessary to be at all to be done by cancer expert and cancer research. It helps, but it is not necessary. The definition of oncology, according to Merriam-Webster, is a branch of medicine. It is a science concerned with the prevention, diagnosis, treatment, and study of cancer. It is science. Global, it means worldwide. So global oncology doesn't mean, as frequently thought, that it is a cancer of control of low middle income countries only, but it is global. Global means global, affluent and less affluent countries. Along the last 3 decades, and still, the gap between required care and cancer care and available was widened in the last 2 decades, and there is no convincing evidence that the needs wouldn't be increased in this 3rd decade of 21st century. This is despite of all conference, festival, reports, commissions, summits, but unfortunately, this is a fact. Recent report in 2024 indicates that there will be 77% increase in incidence of cancer in the upcoming 25 years. With tidal wave among ages younger than the previous decades. So we should be prepared. Is the cancer of problem of the last few centuries that sometimes some claim that cancer is related to divisions, proliferation, and mutations of cells, and started with the first multicellular creatures millions of years before first mammals. Yes, there are some now factor increase some of its incidence, like climate, tobacco, chemicals, etc. For the question of finishing cancer tomorrow to be 0 in the world, including low middle income countries, we state that to be scientific, fortunately, cure, survival, quality of life are improving remarkably. Cancer area diagnosis, detection, and prevention are increased. So every collaboration and effort should be paid for that and not for slogans. The problem is in the affluent countries too. Is not only in low middle income countries with different degrees and variations. According to the American Society of Clinical Oncology, 40% of American citizens, the first cause of fear of cancer is its financial burden and the risk of bankruptcy. In ESTRO, European Society of Radiation Oncology, this is in Europe, 1/4 of cancer patients in Europe didn't get the indicated radiotherapy. You imagine this. In a recent report, an Medscape article, it is stated that the median launch price for 13 new cancer drugs introduced this year was $257,000, which is more than 3 times the median household income for a Californian family. Shall we in the world continue in the same previous approaches? There are very constructive initiatives, but each initiative focus on a needed part of the global challenge. For example, Choose Wisely, the American Board of Internal Medicine led the Choosing Wisely campaign. More than it shows that a list of more 550 examples of unnecessary and low-value services. Common Sense Oncology, an important initiative. Dr. Bishal Giwali will present today also a wonderful presentation about Common Sense Oncology. He is a co-director of, co-founder of Common Sense Oncology with Chris Booth, Richard Sullivan, et al. It's focused on using what could be obtained and implemented in different parts of the world and addressing disparities in funding clinical trials. Several initiatives by important organizations, society, WHO, IAA, individual experts, like calling to focus on essential cancer drugs or generics, drugs or resources, stratified guidelines, or less complicated technology in radiotherapy. Achieving universal health coverage is one of the targets for 2030, 13 Sustainable Development of United Nations. However, we see that it is obvious the skyrocketing increase of cost of cancer care and new drugs that don't commensurate with the increase of curve of improving outcome is a big barrier to achieve such goals of the universal coverage, universal health coverage. So it should be we should be have attention for this. As a realistic example is a huge big obstacle. Is the waste of the huge big obstacle is the waste on health care. For example, the estimated waste in 2024 in USA health system ranged from $760 billion to $935 billion. It's around 25% of the total health spending. And we speak about resources and funds and the win-win movement introduced by Ahmed, by me, modestly, in December 2007, after inspiring and consultation with many experts and stakeholders in the world. I didn't invent anything. I based on many evidence and scientific evidence and publication by many. Aims at the increase of affordability of better value cancer care for millions of underserved cancer patients in the world, in rich countries and in low middle income countries via scientific approaches and within win-win scenario. It is not competing or replacing any, but it is a forum for all. It belongs to and owned by all and owned by all. We don't claim any invention. It is based and inspired from scientific work of many scientists and authors. We don't seek for any glory, but the glory is for the real doers everywhere. The win-win is a new notion and not a competing body. So it could be adapted and adopted by any. The win-win is a message of love, but not in words, in words like I love you, or slogans, but it is expressed in scientific exploration, collaboration to serve the cause of affordability of better value cancer care with dignity for all, regardless their nationality, beliefs, or color. Why win-win in the real world? It should not be satisfied with not less than patient-centered value cancer care for the majority of population in the world. The interests and incentives for all stakeholders should be considered to be in the real world. To be realistic, incentives and remuneration of professional cancer care are mandatory, should be considered and repaired. Otherwise, the different ways of corruption under different names or abuse resources in different parts of the world will continue. But it needs smart and innovative scientific focus approaches and broad scope intelligent deals. Even the industries will flourish more and enormously increase their markets. There is a need to change the present game, and for a think tank like that proposed by President Franklin D. Roosevelt for the New Deal. The two wings of the win-win international scientific initiative are to increase affordability of better value cancer care via scientific approaches, exploration, education, studies, and win-win model. Two, to increase the number of quality of care service in the world via catalyst action. We don't pretend or claim that we do all. Via catalyst action, relevant education and training. It is a great need for wide education and training programs focused on the goal on how to enhance the human capacities and resources that adopt and lead scientific movement to increase affordability of triple value cancer care, the patient, the community, and science. For millions of cancer patients with dignity, as soon as not just the usual ready-made programs or stereotype repeated curricula, or to repeat the same thing, there are many. Global Oncology-Implementing Science program, created, is a part of Global Oncology University, is an example of collaborative model that could contribute in serving this defined goal in the world with all of you. In the Win-Win Initiative, the Global Oncology Implementing Science virtual program, some of the notion is important notion is that we advocate for brainstorming and stimulating global collaboration for exploration of unlimited number of scientific approaches and studies. We present and openly discuss tens of published scientific examples in different fields of cancer care. Also, we present a real-world example of success, collaboration, and initiatives to provide approaches to expand number and value of offered cancer care, and the win-win modified blue ocean strategy that entails enormous increase of opportunities to expand services via global win-win models of coordination and cooperation. Once again, all will gain. In the next webinar, we'll explain many of these things and in the course before. Some of the important notion of the other important notion of the win-win initiative is no rivalries. All initiatives and players are needed. The problem is not in the players, but in the game. Classic and innovative scientific approaches, brainstorming, flexibilities of thoughts, and free flows of ideas. The interest and incentive of all stakeholders are considered. All win-win. With smart approaches, the present winners will gain more, and the present loser will have opportunity to obtain their need with dignity. Question 1 to all. What is the global value of new treatments and more cost if it is not affordable for the majority of cancer patients in the world? What's the value? 2, what is the value? What is the global value of awareness, screening, and early detection if the patient have no access to affordable and nearby care with dignity? I leave the answer to all of you. It is waste of time to think what is more important. It's but it should be a global balanced approach. The GOIU starting in 2017 and there is a link for Global Oncology University, prioritization for all. Implementing science seeks to continue the job. Biomedical research or discovery or study or trials, whatever scientific importance and value, would not be complete except with the scientific study for its use and in practice. And we stress on scientific studies on how to be accessible and affordable in the real world. Global Cancer Fund, is that will be the solution? It helps, but it is not the magic soul big solution. Whatever the amount of global and local levels, the richness of a country, then if we don't adopt scientifically value-based care and approaches that include reducing the waste, then it will be like trying to fill a tank while there are many big holes at the bottom. We cited many examples of how to reduce the cost, and this will be in the next webinar and be in the courses before, and we have in our books, and there will be more details in the next sessions. For example, how to reduce the cost of 100,000 or more per patient for certain cancer drug in USA. It's possible. Professor David Kerr will present this in more details, and I'll present it, and our distinguished colleagues too. For some other example, it's scientifically possible to reduce the cost of scientific ways by 70 to 80% without compromising the outcome on patient. Please see examples of reference below. We stressed on what we published by many authors the need of revisiting and the reassessment of doses of all new drugs, particularly targeted and immunotherapy of cancer and clinical trials. Doses could be more optimized on scientific basis. The high cost will be reduced and avoid unnecessary toxicity, all without compromising the outcome, and even to get better value, better outcome on patient health. After many publication, presentation, and pleas by many experts, now we have great news. This is Project Optimus. It is by the Oncology Center of Excellence, PDA. It is for reforming the dose optimization and dose selection paradigm in oncology. The goal is to educate, innovate, collaborate, and with companies, with academia, with professional society, with international regulatory authority, and patient to move forward with a dose finding and dose optimization paradigm across oncology. Some example, to cite one example of the West, it's a shocking example of the West. There are many, but I sit here just for example. You will have in the other webinars after. The waste of leftover in vial for some expensive cancer drug in USA is estimated to be $3 billion per year. And we speak about the resources. Are there solutions to reduce enormously this waste of $3 billion on the leftover? Yes, it is published. But who listen? It is possible to treat double or even triple the number of patients with the existing present facilities of radiotherapy. In many countries, yes. Many authors and we presented different approaches for how to do. For the last point, to be in the real world, will that decrease the upcoming plans and expansion and sales of manufacturers of radiotherapy device? No. It will be the most important, operational way to show how radiotherapy is cost-effective. Hence, with smart approaches to open weak or dead, even dead market for the needed new, at least 10,000 radiotherapy and clinical oncology service. Question for all organizations, institute, different philanthropic initiative and government. If you have a sum of money or fund, do you spend on purchasing some medicine for some stratified resources care in order to offer to fraction of underserved patients as a way to increase access? or it will be more of more value if you spend this sum or part of it on scientific and smart approaches to increase affordability of better value cancer care with dignity for millions of underserved patients in the world. All will win. I leave the answer for you, to all of you. In the upcoming third and fourth and fifth ASCO International Webinar, we'll tackle many published examples and approaches, how to, via scientific approaches, to lower the total cost of systemic cancer therapy. And also that we have 4 webinars concentrated and focused on how to increase access and affordability of radiation oncology and prospect of molecular radiotherapy. It is a miss to consider many lower middle income cancer in Africa of limited resources. Most of limited low middle income countries have the curse of having rich resources. Is a solution to send some funds or begging or charity from rich countries to Africa or other low middle income countries? No, no, no. Should be well scientifically planned, transparent, win-win approaches. Every US dollar should have its positive return on both taxpayer in rich countries and citizen in low middle income countries, and scientific progress as well. No one should lose. All stakeholders should win. The present winner will gain more and not less. The present underserved will get their requirement with dignity in the real world. But if you continue as we are, the crisis will increase for all. Isn't the time to be a game changer together as organization, independent, coordinated efforts, all stakeholders, institute, and all within a global win-win smart campaign based on scientific realizable approaches? I leave the answer to all of you. Finally, the only hope for success of this scientific initiative is to be adopted, improved, implemented, and led by many. The question, how to do we have a chance to succeed? Yes, if adopted by all, and everyone study how to increase the chance from his side with every institute, every all partners. The win-win international scientific initiative belongs to all, and surely to all of you. The message is for all stakeholders. It is also for all the younger generation, and we ask them to advocate and to raise the flag for better near future. Thank you, and warmest welcome to all. This is my email and website. Please, we welcome all your feedback and contribution. Thank you all. I'm sorry that was this talk was long, but it is really overview of what inspired from many colleagues. It is not one-man show. Now, I'm glad to introduce Professor Hussein Khaled. No, Karol Sikora, sorry. Before Hussein Khaled, I am honored really to present my old friend and the leaders of many initiatives in the world, and one of the leaders of global oncology and radiation oncology, clinical oncology, and many things really, Professor Karol Sikora. And as you see, we are very open to your comments, to your criticism, to your open ideas, as far as we are together.
Hello, it's Professor Karol Sikora here, an oncologist based in London, UK, talking about is it time to change the game in getting better, more effective use of the resources we have around the world. I spent a couple of years as the WHO Cancer Director, and I've been to all sorts of places, and for the last 20 years I've set up sustainable cancer centres in networks in the Caribbean, in the UK, and increasingly in Europe. The way cancer care is going is all about delivery in an efficient manner. It's keeping doctors out of chemotherapy units, changing the way in which radiotherapy is practiced, because we do have very good IT now that we didn't have 20 years ago. My generation and our leader, Ahmed, now one can deliver very sophisticated radiotherapy in small centers all around the world. Very sophisticated chemotherapy, again, in all centers. This means the costs can be reduced, and that is the key to effective, efficient oncology care, reducing the costs. The problem is, it's not really a win-win, and I would disagree with Ahmed about this. There are going to be losers. There have to be, if any change results in winners and losers. And to pretend it won't is crazy. So the clear loser in all this will be the purveyors of high technology, which is ineffective. If you look at it, big pharma selling drugs that are billion-dollar markets, but very little therapeutic gain in many patients. Sure, for some, we can make predictive evaluation of whether a drug's going to work before we use it. But on the whole, we're still in the era of the Stone Age in terms of predicting molecular signatures. I think not enough attention has been given to dose reduction. We'll hear about that in this seminar. And also the use of generic drugs, which are so much cheaper than the latest off the shelf from big pharma. To make things efficient, we have to have protocols that can transcend the economies of countries that don't have the resources. And we can make those. It's easy to do. The problem is always the top 2% in any country want to have world-class, American-style mainly, therapy, and that's going to cost money. So we've got to educate people. That isn't the holy grail of oncology. A vivid example, a patient of mine a month ago, metastatic pancreatic cancer, failed 2 different chemotherapy combinations. We all know the results are dreadful from this disease with existing therapies. He was very wealthy, decided to go to New York and get a second opinion at Memorial Hospital. He came back $200,000 poorer and said, "You were right, there's nothing that can be done." That's the sort of situation we have to avoid. That was totally inefficient use of his money. Okay, he has plenty, it doesn't really matter on the scale of things, but that's what we've got to fight against. Irrational behavior inspired by people given hope by the media for things that really are unachievable. Sure, there are all sorts of potentials out there, vaccines for cancer, multi-cancer detection tests and so on. They all hold promise, there's no doubt. But that type of report that comes out now and again that suggests that certain types of therapy are the answer if you could only get it. And the cancer patient, instead of behaving in what would be a rational way, starts seeking out this holy grail that is imagined and, of course, sold through the media to them. That's the problem we're facing, and I know we all face it all around the world. And in fact, in the poorer parts of the world, it's much harsher because you can't even get the basic drugs that we know work together in a package. So if you take ABVD and BEP for different diseases, you just can't get them necessarily, and they're not expensive. So getting the achievable that would have an effect is much more important than trying to get the latest and greatest. The problem with dose reduction, You know, the losers there are Big Pharma. They're not going to vote for it. Turkeys don't vote for Christmas. They're not going to help us do that. So I think it's knocking your head on a brick wall. Instead, we've got to have rational protocols for treatable cancers based on generic, cheap drugs at effective doses and effective number of cycles. And in that way, through patient and staff education, including staff, the chemotherapy nurses, and in radiotherapy, the radiographers or the radiation technologists, it's really important that they understand the limits of what we can do and not try and always want to be beyond those limits. That's the only way we can make cancer care of decent quality for everybody achievable over the next decade.
Thank you very, very much, Professor Karol Sikora. And you are one of the main leaders of this initiative, really. And as you see, we have it is a forum for all views to brainstorming. And also, I would like to say that it is win-win. To work, it should be win-win, and to stop losing that a big fraction of the world loser to be realized in the future, in the present and the future, should be win-win. And this is our role. Otherwise, our new generation will meet after 20 years to speak about that is impossible and about the huge interests and the huge financial incentives that blocks increased affordability of better value cancer care. That is why we need to think tank, to be smartly and not hardly. And there are many ways to increase the cost and to open markets, and all will win. They'll increase the sales for many. That is why I consult most of the time of industries. That is not say that they are okay now, but they realize that there is a crisis. The world can continue like this, can continue like with the concept of losers and winner, and there's our big interest should be win-win to hear to us. This blue ocean win-win modified strategy, and there is much details after. And now, Professor Karol Sikora, thank you very much, and we need to discuss together. Always, we are one of the main pillar of this initiative. Professor Hussein Khaled after. He's the ex-minister of higher education and professor of medical oncology in Egypt.
Hussein Khaled. I am a professor of medical oncology at the National Cancer Institute of Cairo University in Egypt, and I served as a member of the UICC Board of Directors during the years 2016 to 2018. How can we recognize and address cancer as a major global health concern that is severely straining health systems? And how can we address the increase in the gap between the required and the affordable better cancer care? In the year 2012, the United Nations General Assembly has adopted a slogan that said to decrease the deaths from non-communicable diseases, including cancer, by 25% in the year 2025. And then, feeling that they will not achieve this goal, the slogan changed to reduce by 1/3 the mortality of non-communicable diseases, including cancer, by the year 2030. And they put 9 targets to achieve this important goal. Did we achieve this goal? I think if we look to the numbers and we see the time trend analysis of age standardized incidence rates between the years 2012 to 2022, there is an % increase in this incidence rate by 8.2% globally. And this was, if you divide it, there was a decrease by 3.6 in US, decrease by 2.7% in Europe, and also increase in the incidence rate by 39% in Africa. In addition, if we look to the age standardized mortality rate, we will see that there is globally a % decrease in this rate by 10%. This rose to 13.6 in US and to 7.3 in Western Europe, and on the contrary, increase in the age standardized mortality rate by 13.7% in Africa. So did we achieve this goal? The answer is clearly no. At the same time, what is the time trend increase in the cost of cancer drugs? If you look to the data from IQVIA, we said that we see that in the year 2019, the total cost of cancer drugs in the year 2019 was $148 billion US, and this number increased to 255 in the year 2024, and it is expected to reach for more than 400 billion US dollars in the year 2028. Astonishingly, and in one article from Sweden, the cancer drug reimbursed with limited evidence on overall survival and the quality of life was published. And the study included many diseases, many cancer diseases: renal cell carcinoma, non-small cell lung cancer, breast cancer, ovarian cancer, melanoma, Hodgkin lymphoma, and so on. And astonishingly, there was 68% no evidence of improvement by these drugs regarding the overall survival nor the quality of life. So what is the way forward? The way forward is to invite the governments to apply precision cancer control planning, improve data acquisition and cancer registry, especially in low-middle income countries, design healthcare systems that promote equity and access, increase cure and improving care, effective palliation, building and maintaining the health infrastructure workforce, innovation and research, and more importantly, investment in telehealth. By this, I thank you for your attention, and I hope that we could achieve this goal in the future.
Thank you very much, Professor Hussein Khaled. Now, I'm glad to present to you Professor Will Negwa, who is the co-founder of the GoU, co-founder of all this show, and of Global Health Catalyst. And really, he is working hard in this endeavor. I have the honor to present my friend, my brother, Professor Wilfred Negwa.
Hello, everyone. Thank you so much for joining this course today. I really want to thank Professor Ahmed Elzawawy for being a champion for global oncology education, especially for this implementation science course in partnership with ASCO. So today I'll be talking to you about an example of collaborative virtual global oncology education. So I was privileged to be a chair of the Lancet Oncology Commission for Sub-Saharan Africa, together with colleagues Professor David Kerr and Dr. Beatrice Adai. And one of the key things that the commissioners, over 54 of them, found out was that the challenge of cancer now faced by Sub-Saharan Africa is enormous, with high incidence and death rates. A key call to urgent action coming out of this commission was to invest in building and maintaining the workforce. So currently in Africa, this workforce is characterized by severe personnel shortages. The oncology to patient ratio is very, very low. And there's a lot of inefficiencies and gaps in service coverage. And so this is a really big crisis. In fact, now I co-lead the Lancet Oncology Commission for the US Cancer Moonshot, and one of the focus of this is really workforce development as collaborations across the world to really build workforce that can join the fight against cancer globally. So one of the recommended collaborative approaches from the Lancet Oncology Commission was the Global Oncology University. So this Global Oncology University model was actually launched through sessions and collaborative sessions at Harvard during the Global Health Catalyst Summit a few years ago. And it really goes like this. If you have 2 hours a week, or let's say a month, or even a year to contribute, you can be invited as an invited lecturer or professor to contribute a time. You basically pool that time along with that of other professors who may also have 1 or 2 hours to contribute. And then artificial intelligence essentially schedules your time, coordinates that across the curriculum, or you can teach the whole curriculum that way. So you come and enjoy, you give a 2-hour lecture or 1-hour lecture. You have trainees from across the world to get access to the best professors like you. And then trainees also have the opportunity to get access to the best professors across the world. And then these online lectures can be complemented with practical training at regional sites. These regional sites have been credentialed. So basically we've gone there, we've seen that they have the infrastructure that will allow the trainees to be able to have that practical training. And so when they complete that practical training, the local person supervising them can sign off and they will get the credits. And then it can be awarded a certificate or a degree, or be allowed to sit for the board exam. So right now we have a number of partners across the world who are serving as credential sites, and we're very, very excited about this. So some of the advantages and potential impact of the Global Oncology University is already growing impact, is that this really overcomes geographic barriers that are crucial to oncology training. Also, trainees don't have to pay any tuition, but they can have the best quality of education from the best professors as well. It's relatively harmonious, so it means that trainees from Tanzania can have the same training as trainees in Nigeria or Bangladesh or Macedonia or Brazil. The quality of education is really, really high. Also, an advantage is that we don't have to talk about brain drain in the same level that we talk about right now, because you can really have diaspora oncology health professionals to co-teach these courses and really turn brain drain to brain circulation and global health gain. So over the past years, we've trained thousands of oncology health professionals in Africa that way. We recently trained oncology health professionals in Ukraine, in Eastern Europe, in Pakistan, in Southeast Asia, and other parts of the world. And this is really growing to be a really powerful way to use virtual platforms to teach and increase access to the best quality education. Currently, we are also supporting this Global Oncology-Implementing Science course, and accreditation is now in progress. Just this year, we are very excited that we've got literally millions of dollars in funding to support the launch of graduate and residency programs. So I would like to really welcome you to contact us if you are interested in teaching or participating in one of the courses and learning about the upcoming curriculums that we have for this fall and into the next year, and even funding opportunities, please visit us or contact us through the ISADOC website, the GOIS course website. Thank you very much.
Thank you very much, my brother Will. And as we agreed together, that will be what is important is what is the work after. And I am honored to present a leader from Harvard and leader in global oncology. And she is associate professor of medical oncology and director of many interesting programs. You have the details in the brochure, and we'll send you all. Aparna, please.
Hi, my name is Aparna Parikh, and I'm a GI medical oncologist at the Mass General Cancer Center. I'm also the director of our Global Cancer Care program. Thank you so much to the organizing committee for having me today. I'm sorry I can't be there in person. So I was asked just to speak briefly for a few minutes around the need for more scientific approaches and implementation science to really help us think about affordability and value of cancer care in low and middle-income countries. As a big disclosure, I am not an implementation scientist, nor do I have much experience in implementation science. However, as an oncologist and as someone who thinks around care in low and middle-income countries, have really thought a lot about the role of implementation science in conceiving and contextualizing and scaling cancer care and prevention programs in low and middle-income countries. I think the last few years, I've really started to appreciate how important implementation science is in addressing cancer care and control strategies for several reasons. So I think really only until I think the last 5 or 6 years have we really started to appreciate, I think in cancer at least, the importance of implementation science. To date, especially in low and middle-income countries, there has been really limited research to help us and guide the adoption, the adaptation, the integration, the scaling up and sustainability of cancer control interventions that are really geared for low and middle-income countries. I think we have learned that implementation science is critical in order to inform strategies. And I think where we have seen this, and I have learned a lot from, is in the HIV space. And so one area that I've been working in is trying to leverage the existing tremendous HIV infrastructure in India. And can we piggyback on that infrastructure to really work on cancer screening strategies for patients living with HIV, again, learning from what we've learned in terms of the HIV framework. So one thing I really kind of started to think about and started to become a little more proficient and kind of familiarize myself in this space was when I started becoming a faculty member or joined as a faculty member in the Ariadne Lab. And Ariadne Labs, as some of you may know, was founded by Atul Gawande, and was really designed to promote kind of equity and equitable healthcare for everyone across the world, kind of high value problems and high value solutions. And really what they kind of thought about as they were thinking about their model is, and this is right off their website, if you look at it, was talking about the gap between what we know should be done in theory and what actually should be taking place in clinical practice. And they use this ARC. So it's called the Ariadne Labs ARC. And it's basically a pathway, a 3-stage pathway for innovation. And it really thinks around how we kind of design strategies and how we test those strategies and then ultimately scale those strategies up. But the key here is that in that process of kind of designing and testing and scaling up, everything is evidence-based. And that evidence base is to really ensure that the models and the systems are really bound by the highest standards of science. With those guiding principles kind of grounded again in evidence base and science, there is ability to iterate and kind of refine the interventions such that they are fit to the appropriate context. So I think some of the reasons I think that implementation science is really critical in these countries is, I think, one is to really help us think about resource optimization. We have to really be cognizant of the efficient use of resources, ensuring that interventions are cost-effective and sustainable. The implementation has to be contextualized, really taking into account unique cultural, geographic, socioeconomic context of these countries, really allowing us to tailor approaches based on the needs. Again, this is all focused around access and capacity building, but again, bound by evidence-based practices. And ultimately, with the hope that this can really shape policy and advocating for changes that prioritize cancer prevention and treatment and healthcare agendas. So in short, I think that implementation science is essential and for creating effective and sustainable cancer control strategies. Thank you.
Thank you very much, Aparna. And we count on your contributions a lot, and active contribution and leadership in this endeavor. Maybe you hear in this webinar a big introduction and to convince ourselves that there is a need, there is tragic lack, and there is a need to change the game. We cannot continue as we are. And in the next webinars, we'll speak science, speak about practice, about pharmacology, about radiobiology, how to really to present tens of examples on how to lower the cost of systemic chemotherapy, systemic therapy, systemic immunotherapy, without compromising the outcome, and even to get better value. And there are series of 4 webinars focused on radiotherapy and molecular radiotherapy and perspective on molecular radiotherapy and how to increase affordability of radiotherapy in the world. This is how. It's not there is need. Today we speak there is a need. Yes, we are convinced, we know, but we should not complain all the time and to say that they are loser, we have to lose. And no. How? As doctors, as scientists, as radiation oncology, as clinical oncology, as surgical oncology, as pharmacologists, as physicists, as chemists, what to do, clinical trialist, how to do. And there are many things, and how to translate this into a pathway to change the game, and all will win. I am glad now to present a co-founder of a very interesting initiative, but I do hope that we collaborate together, work together. This Associate Professor Dr. Bishal Gwali who is the co-founder of Common Sense in Oncology, with Christopher Booth and with Richard Sullivan and other colleagues, distinguished colleagues. Welcome, Bishal.
Hello, everyone. This is Dr. Vishal Giwali from Queen's University, Kingston, Canada, and it's my pleasure to be with you all today virtually for the ASCO-GOIS Symposium, and I'll be speaking about cancer groundset and common sense oncology. If we look at the data, we see that many patients with cancer in the world, they die because they lack access not to the shiniest new molecule, but to the proven interventions that we already know work. Interventions like surgery. If you look at the status of global cancer surgery, less than 25% of the patients with cancer globally will be able to receive safe, affordable, or timely surgery. If you look at the situation with radiotherapy, it's no better. More than 50% of patients in LMICs, they lack access to radiotherapy. If you look at low-income countries alone, more than 90% of our patients lack access to radiotherapy. And these are the interventions that actually help patients. And we have proven this over and over, but they lack access to these basic fundamental cancer treatments. This was a very heartbreaking news that I read back in 2017, showing the access to radiotherapy for cats and dogs in the United States seemed to be far better than the access to radiotherapy for several patients in the world. There are many countries in the world that lack access to a single radiotherapy machine. But what gets more attention in the media and all over the world globally is about how these new moonshot programs are going to cure cancer. What gets more attention and funding is about how precision oncology is going to solve this problem of cancer, how immunotherapy probing into genomics is going to help us solve the problem of cancer. But the problem, in fact, is all these fundings and attention and concentration has been dedicated to the so-called moonshot approaches, and there is lack of funding and attention and dedication to actually implement the interventions that we have already proven to work. So artificial intelligence is not going to solve our problem. We need a natural common sense that focuses on implementing the interventions that we have already proven to work, that already helps lots of patients. If you look at this graph shows the mortality rates from cervical cancer all across the world, and the redder the country is, the higher is the mortality rate of cervical cancer. And this is a very sad graph because we know how to prevent cervical cancer. Cervical cancer is the only cancer where we can talk about elimination. And still, so many countries in the world have such high mortality rates from cervical cancer. But countries like Australia and New Zealand have proven that you can actually eliminate this disease. But when we are talking about cervical cancer prevention, people are more interested in the newer immunotherapy molecules that will improve survival of cervical cancer patients by a couple of months, when in fact nobody should have cervical cancer to begin with because of the screening campaigns and the vaccinations. So that is what we mean by cancer groundset. Cancer groundset is a movement that we proposed that should go parallel to cancer moonshot and should focus on implementation of treatments that are already known to work and should incentivize research on affordable and cost-effective interventions that can be applied globally. We held a seminar on cancer groundset 2 years ago at the ASCO annual meeting as well, and we have published this on ASCO educational book as a book chapter as well, which I encourage you to read. So looking at these things, getting our priorities wrong, prompted me to ask 7 years ago that are we losing common sense in oncology? Our simple common sense in cancer care should be that our interventions should help our patients to live longer and better, and we should make sure that those interventions reach the patient. So 2 years ago, in fact 3 years ago, we wrote this paper asking for a common sense revolution in oncology. We wanted the society to change the way we think about delivery of care, research and policy, and education. And then we realized that we actually should do this as a movement. So 2 years ago, we started Common Sense Oncology as a movement. This was a gathering of people from all over the world representing major stakeholders, physicians, patient representatives, and physicians from different disciplines. So we gathered together in Kingston, Ontario to formulate a Common Sense Oncology movement, and we published our manifesto in Lancet Oncology. In detail through this publication, but this is our bottom line. Common Sense Oncology will promote interventions that measurably improve the lives of patients. We will celebrate well-conducted trials and promote effective treatments, but we will also speak up about and challenge the interventions that might cause more harm than good. So I encourage you all to go to our website www.commonsenseoncology.org or follow us on our Twitter channel @CS_Oncol. And we are focusing right now on common sense oncology principles integrating into evidence generation, that is the designing of clinical trials, evidence interpretation, and evidence communication. So thank you very much.
Thank you very much, Bishal. And going forward in fruitful cooperation, this is what we need really to make a campaign together. It will be all will win. Now, I am very glad to welcome a newcomer to the win-win and to Global Oncology Implementing Science. Really, I am glad that Dr. Jack Bizwi Dentout, I hope that I pronounce his name well. And I count on, you heard also about these webinars, our hope to stimulate really radiotherapy in the world beside systemic therapy in general, beside all cancer care in the world. And these webinars will be alternatively with the systemic therapy. I count much on Professor Luca Incroci, Professor Karol Sikora, and on Abba, and on Jack, who I'm glad to present him now, to cooperate together to make this part of radiotherapy and to push it forward together and to be realizable progress in the world. Welcome, Jack.
Good afternoon, dear colleagues. I'm Dr. Jacques Bezuidenhout. I'm an attending radiation oncologist working at the University Hospital in Brussels in Belgium. I've always had a keen interest in global oncology, partly given my background of growing up in South Africa. And in this regard, I'm an extended member of the ESMO Access to Cancer Medicines Committee. I recently had the honor of being asked by Professor Elzawawy to get involved in the work of the Global Oncology Implementation Science movement. And for today's webinar, I was asked to give some selected remarks on the introduction as presented by Professor Elzawawy, and also some general remarks on the goals of today's webinar. So the first point I would like to stress is that it is extremely important to frame global oncology not as a science only affecting low and middle income countries, but most, if not all, countries on a global scale. When I look at the European setting where I'm working in at the moment, there are, for example, two initiatives looking at these inequalities in access. The one is the Cancer Pulse on Inequalities, managed by the European Cancer Organization, and the other one is the European Cancer Inequalities Registry, managed by the European Commission. And this is an example from the Cancer Pulse on Inequalities from Belgium, and it looks at women that reported to have never had breast examination by X-ray differentiated per income level, and you can see that there is a big difference ranging from 4% in the very high income group to 18% in the very low income group. And this just illustrates the fact that inequalities or disparities in access are also very much prevalent in so-called high income countries. And I think that to move the field of global oncology forward, it is important to really frame global oncology as a science affecting all countries of the world. Then just some words on the cancer moonshot versus cancer groundshot approach. As you might know, the cancer moonshot campaign was started by the Obama administration in the US, and with a main focus on high-tech science and big data. And this led to some very prominent people in the field calling for a more complementary approach, which they called the cancer groundshot approach, with co-development involving countries with different income levels working together to discover cancer strategies of common interest, to make sure that uniform access to treatments that are known to work is promoted. And this feeds into the global health systems and implementation agenda. And very importantly, calling for patients to need and get better care, not just more technology. Another important point raised by Professor Elzawawy in his presentation is the issue of wasteful expenditure in oncology. And here I would just like to mention this article published this year. It's set in a Slovenian setting, and it looks at the increased use of novel, expensive systemic therapy at the end of life, defined as the last 2 weeks of life. And then you can see in the period from 2015 to 2019, there was an increase in the use of targeted therapy, immunotherapy, and biological therapy, while actually the use of chemotherapy stayed the same or actually decreased. Now I'd like to give some general notes on the goals of the second webinar. So the first goal was to discuss notions and needs for the science of global oncology. In this regard, I think it's very important to make global oncology truly global, as this would create an opportunity to address inequalities in countries with different income settings through partnerships. The second goal was to look at the use of implementation science to increase the affordability of high-value cancer care. In this regard, I think it's important to identify and address context-specific barriers and enablers to the uptake of evidence-based clinical innovations in oncology. And in this regard, I would like to mention the recent report by the Lancet Commission on Radiotherapy and Diagnostics, where they actually looked at the annual cost saving if hypofractionated radiotherapy would be used instead of conventionally fractionated radiotherapy. And here you can see that there would actually be annual cost savings in all income level countries, from low income countries to high income countries. And I think this illustrates the fact that implementation science needs to be used to really put these evidence-based approaches into daily practice, because it leads to cost saving and also the safety and efficacy of hypofractionation, for example, in prostate and breast cancer, have already been proven. Also in low and middle income countries, for example, the Hypo Africa trial looking at hypofractionation in prostate cancer. And then the third goal of today's webinar was to look at future directions for collaborative global cancer case studies and implementation. And I think in this regard, it is important to define what exactly high-value cancer care means to different stakeholders in different contexts. Does this only address cost effectiveness? Does it also include affordability, sustainability within the healthcare system? And does it actually also include acceptability of different innovations to people living with cancer? Then I think given the importance of implementation science, it is very important to provide training opportunities for capacity building in this field. And more general, I think there's a need for more global coordination also between the different specialties, surgical oncology, radiation oncology, medical oncology, to avoid working in silos. Thank you very much.
Thank you very much, Jack, particularly for the notes that you included in your presentation. I think that we will consider, if you agree, together in the conclusion and future direction, and to summarize the goal of this webinars. I think that we'll have to work together with Abba and me and who would like from colleagues to formulate conclusions and future direction, and then corrected and revised by all colleagues, the panelists and the attendants here, and then to be a report and a publication and to a document that for follow up for what's coming after. Before presenting the important next speaker, I would like that you prepare together now for the remaining half hour for discussion. If you have points to raise, if you have comments, if you have criticism, if you have idea, please send it now, and we will discuss it. Also, if after the webinar we would like to have more ideas, more suggestions, more things, this is a forum for all of us, and this is our win-win initiative together. This is Global Oncology belongs to all. So you can send us after. Now, I am very glad, really, to present a very important element active in the world for the question of access to cancer care. I am glad to present Katrina Schippers, who will present to us the contribution of the Max Foundation in access, increased access and of care and diagnosis in the world.
Hi, my name is Kathy Schippers. I am the Region 8 for Africa Middle East with the Max Foundation. The Max Foundation was established over 25 years ago and has since helped over 100,000 patients in 80 countries reach access to critical treatment and care. We are on a mission to accelerate health equity. We do this by the delivery of medication, technology, and services to patients with cancer and other critical illnesses. And we spend all our energy on those patients that nobody else is helping. We have a vision of a world where all patients can access high-impact medication, where geography should not be destiny, and where everybody can strive for health with dignity and hope. As I've mentioned, we work with the donation of medication. So we have several pharmaceutical companies that donate their treatment to us. We work with a network of physicians in several of the lower middle income countries. And through their support, they help identify patients that will benefit from these treatments. The Max Foundation then ensures that these treatments reach the country and are dispensed to the patients at the right time. Not only do we work with the donation of medication, which act as a catalyst in most countries, but we also help develop the systems around the treatment to build out things like the diagnostics, the patient education, the patient support, advocacy, and other variables that impact patient outcomes on the journey. As we know, there are several variables. It's not just within the healthcare system, but it's usually within the ecosystem of the patient that act as barriers for patients to get access to what the care and treatment they need. And we work in each country with the country partners that start from the ground up, which are the patients themselves, through patient networks, patient advocacy groups. We work with physicians, ministries of health, laboratory partners, our pharmacists, nurses, social workers, anybody within the health system or within the ecosystem of the patient to help identify what those barriers will be. And then we see where, as the Max Foundation, we can plug our programs, our activities, or any of the interventions we have within that system to help patients cross the bridge to access the treatment they need. We have several programs that are built around the therapy. It's not just the donation. As I've said, we have a diagnostic program where we support access to diagnostics in several countries, either by donating tests, equipment, providing training, or paying the service providers in the country where patients cannot afford it. We have a program, for example, that helps patients get to the clinic by reimbursing them for their transport costs. And in some countries, we even have a program that pays for the schooling of the cancer patients while they are on treatment, as we know that the cost of medical care is so high that they often have to take their kids out of school. We work closely with our patient community by ensuring that they have the most updated information about the disease, but also the updated information about the treatments and the services that we offer. And then we cannot do this by ourselves, so we partner with various other organizations, NGOs, as I've mentioned, ministries of health, physicians, any like-minded individual that believe in participation, being proactive and positive in the path forward in developing these systems. And we believe, in all honesty, that we can close the treatment disparity gaps, as we have proven to do this with some of our programs over the many years we've been running it. Thank you so much for your attention. If you need more information about the Max Foundation, please visit our website or reach out if you have any questions. Thank you.
Thank you, Katrina. Thank you, Kathy, for the great work, really, of Max Foundation. And welcome on board of Max. I say to all colleagues of Max Foundation, really, and for your noble work, really. Now the stage is open for all of you, and if you have questions or have comments, if you have even criticism, this is your forum. This comment of Moy, why not, Moy, you send the question, why not if you open your mic and present yourself and present the question?
Okay, I can do that.
Yes, please.
Good evening,
Welcome.
everybody. Thank you. Good evening, everybody, and thank you so much, Ahmed, for this wonderful opportunity. I've learned a lot, and like I said, I'm the founder of an NGO, and we have a chemo center right now, and we're in the middle of scaling up to trying to get a comprehensive cancer treatments going in Nigeria for so we can close the gap, just like the lady from Max Foundation said, between those who can afford to have treatment and those who can't. My question was about the GOIS courses. Does it include radiation therapists, radiation therapists and medical physicists as well? Because there's a lot of shortage in those areas too, or is it just for oncologists?
GOIS is constitute a program in the Global Oncology University. In the Global Oncology University, Global Oncology University, we have programs for medical physicists, and it is going with currently. And I send you my slides if you like. I send my slides for all, and you find access to Global Oncology University site. And if you even visit our website, 3w-isodoc website, you'll find access to Global Oncology University, which is program. We have program for surgical oncology. We have program for medical physicists. We have program for care in general. And really, I'm grateful to Will Negwa, Bashkim, Siful Haq, and Siful Haq was the past president of the Society of the National Society, American Society of Medical Physicists, and Stephen Avery, professor of medical physics in Pennsylvania and radiation oncology, who are forming programs really for, yes, it is this. Yes, this is the website. Thank you, Mahmoud. This making program for physicists. We have hope even to have to establish a degree and accreditation, because what is needed is not only courses, but it's needed really to make it to obtain degrees, to obtain some qualification, and the Global Oncology University are working in this. In Global Oncology University, this is part, Global Oncology in GOIS, this is part of, focused on how via science increase affordability of better value care, and via education and training. So it is a whole group together. Welcome. Just visit our website and you click on Global Oncology University, and I can connect you with my brother Will, Siful Haq, Avery, and all. Thank you.
Okay, thank you.
If there is any other question, Karol Sikora sent his email. This is to all of you. Who is that? Sheila? Sheila, Kurt, if you are still there, please present yourself and present your comments and your question. Sheila. And this comment was for Professor Karol Sikora. The question was for Karol Sikora.
Sorry, Ahmed, I can't get the question. What was the question? Sorry, I can't see it.
Yes. Hello again,
Hello.
Professor Karol. Do you remember when both of us, this is from Sheila Cartwright, when both of us standing up for the combination of conventional and alternative medicine?
I remember.
Yes. Well done. Congratulations on everything you have accomplished. Dr. Chella Cartwright.
Sheila Cartwright. That's
exactly. I'm sorry for
yes.
pronunciation. And she is consultant in clinical oncology
It leads.
in Leeds. Yes.
Very good. Now, I think that the problem we all have is that the irrationality of how we treat cancer. We spend far too much money in the last few weeks of life or the last few months of life, very expensive money in rich countries. And of course, people in poorer countries can't have access. Most of them can't have access to these drugs, but it gives them a sort of false hope, if you like. It's a disconnect between the reality and the aspiration. And we all say, well, it's the beginning of the future. And that's right, artificial intelligence, personalized medicine. But one forgets the drugs now, new drugs that based on personalized medicine are in the $100,000 a year mark or even more, and they're just unaffordable. And if you start looking at individualized therapy, mRNA vaccines for individual tumors, or other personalized approaches such as CAR T therapy, we're talking about $500,000. I mean, most countries' budgets just couldn't handle that. Even if you add top-up payments and so on, it's just not feasible to do that. And so getting the best of what we know is effective using generic drugs seems to be a better way of getting a bigger effect. And, there is this therapeutic plateau. As you put money into healthcare, you get better results, whether it's cancer, whether it's cardiac, whether it's stroke management or whatever, you get better results. But there's always a plateau, at which point the curve goes flat. And you put more money in, but there's no better outcomes. And that's the problem with oncology today. The United States, which drives the intellectually, I would say, and spiritually, the whole oncology business, is way beyond the therapeutic plateau. And it encourages us all to do that. And that's very difficult. It's costing a lot of money. And of course, the winners are the pharmaceutical industry, the big pharma that are selling the drugs. Shareholder value is their holy grail. Whereas our holy grail as practicing oncologists is treat more patients better in whatever economy we are. And I think the idea of sustainability has got to be the future. We've got to have sustainable protocols, not try to do CAR T cell therapy in places where it's just not feasible to afford it. And everything gets cheaper in the end. Everything becomes generic in the end. Okay, it's maybe 20 years before things become generic, but we do get there and it becomes much cheaper. So I think your initiative, Ahmed, is wonderful. And I think the whole concept of this is wonderful, but we have to have a bit of realism about what we're doing and how difficult it is, especially in low middle income countries. It's much more difficult. And also, the rich of those countries can opt out, come to London, Paris, New York, they go where they like. If you're in the top 2% of the economy, they can bypass all the constraints of poorer countries with their healthcare systems and the problems they have. And it's only going to get worse as cancer is going to go up, especially sub-Saharan Africa. It's definitely the biggest rise in cancer will be in sub-Saharan Africa. And that is really worrying.
I agree with you completely, Karol. And we know and we realize together that is difficult. And we do it because it's difficult. Because it's not easy. If it is not easy, then many people will do it. Because it is needed. And by science, we can do a lot. And it needs many smart, innovative way to find ways. And in the next webinars, we have tens of examples how to lower the cost, not speaking about the problem. Today, we speak about the problem, but next webinars, there are many pharmacology, there are many radiology, there are many scientific approaches to lower the cost. It is possible. It is possible to increase affordability of better value cancer care. It is difficult. I agree completely with you, but we do it because it's difficult and it needs us together. I would like to introduce Khaled El-Berry, who is, I think, if he's there, because I would like to count on him a lot in the upcoming phases, because it is on research and reporting this, and Khaled, if you are there? Just unmute your mic. Okay. Katie, we would like to hear from you your comments.
Sure.
And what is more important is just the first webinar in this kind, but there is we look forward for collaboration and cooperation together and translating this into a movement together in the world.
Sure. Thanks. Thank you for the opportunity. I just wanted to add to what Dr. Karol was saying about innovation and the drive. And specifically, as I'm overseeing the activities in Africa, I can tell you how hard it is to reach that North Star of innovative therapy. I mean, for many of the countries we are working in Sub-Saharan Africa, we are just at the start of oncology. I mean, we just heard about one of the biggest challenges is the lack of professionals and trained oncologists, let alone if we think about a health system to support the physicians, you need the diagnostic capacity for individual therapies, et cetera, et cetera. And it kind of feels within the region, as soon as we start to catch up, the benchmark shifts. So it kind of becomes not a win-win, but it's a constant loss. So I do agree that innovation is necessary, but also at what cost? And considering if we can help more, as was mentioned in this discussion specifically with what we have, why shouldn't we? And then it won't be like a lose-win, but perhaps more of a win-win. The reality on the ground is simply that there is an appetite, there is expenditure from our ministries to invest in individualized therapy, where the rest of the world is heading. So we still need to focus on what it is that we currently have, what is available, and how will we get the best possible outcomes. So I think as an organization, we work really hard to ensure that these patients actually, we always also say that even if these things are available it's available in the country, doesn't mean patients have access, right? We need to be very real about that as well. Availability does not mean access in any setting globally, first world or in the developing countries. So we also need to consider what the other barriers are that is preventing our patients from seeing the best outcomes. Thank you.
Thank you very much. And we count on you. And it is not webinars and goodbye, but excuse me that will make embarrass you maybe by many follow-up, by many emails, by many. This is not finished like a webinar, and this is all. So I would like to hear from Jessica and Sarah, because we count a lot on the ASCO, and we are very thankful for them. What we are doing today is the webinar, but what is after is more important. Hello. We have to spread the message. Hi, Dad. We have to spread the message and to make it realizable, and to open it is open forum for all ideas that can serve the goal. Sarah or Jessica, or both, I hope. Yes, Sarah. Hello.
Hello, Ahmed. We are very grateful for your leadership in putting together these webinar series. I just want to take the opportunity to express my gratitude to all of the speakers who took time out of their schedule to join us today. Thank you all for your expert comments. Thank you for being passionate about the field of global oncology, and I'm confident together that we can continue to move the field forward. So we're looking forward to planning the next in our webinar series together. Thank you.
As we say, always going forward hand in hand. We need to be that like that. Okay, if any other comment from any colleagues? Yes, this is Jessica. Are you there? Oh,
Hi, yes, I'm here.
yes. Hello, Jessica.
Hi. Yes, I just want to second what Sarah was saying. Thank you so much to everyone who participated today. And we're looking forward to the next webinar.
Thank you. And before the next webinar, we would like to spread, I send you to all the record. And if any feedback from any, we would like to you will be not only messenger, but leader for this ASCO, to lead this movement in the world. And because the world is in need really for that, a need for your work as ASCO for such a important thing. Thank you, and we count on you. If Lydia is there, Lydia Asana. Lydia? She was there, not present. No, it's present. She's present. Just unmute the Dr. Amal. Okay, I would like that before finishing, we'd like to formulate together with Abba, with Jack, and with all of you, formulate a conclusion and future direction. I think in one of the slides of Jack also he write well some
yes,
part
Dr.
of
Ahmed, I am with you.
Amal.
I'm
Dr. Amal.
Yes.
Yes, welcome. Introduce
Welcome,
yourself,
Dr.
please.
I am Dr. Amal Ali Muhammad, Assistant Professor of Clinical Pharmacology, Mansoura University. Now I am working on oncology site for pre-authorization for chemotherapy, radiotherapy, target and immune therapy in Port-Said, beside the academic position of me.
Yes, in the next webinars, I'll send materials to all, because it is contain many things about our previous lecture, and about as material as brainstorming, and there will be a lot of pharmacology, a lot of clinical pharmacology, a lot of immunotherapy, as and the other webinars of radiotherapy. There are many radiobiology also, and it is also immuno and radiotherapy and all these things, because this is, we translate this into scientific approaches, and we advocate to apply these scientific approaches, which is really published by many, is not invention, and to how to lower the cost of how to get better value cancer care. So be with us in the next webinars. I send you all the materials, send to all. And it's a lot of pharmacology. It is a lot of your profession. There's a lot of clinical pharmacology. And
yes.
As you know, maybe Professor David Kerr also is professor of clinical pharmacology, plus he is professor of cancer therapeutics. And he will present a very interesting things about in clinical pharmacology that helps a lot the issue of affordability, better value cancer care. So be tuned with us, please.
Yes, it's very nice to cooperate with you.
Thank you. Welcome. Thank you. And
Thank you.
welcome always. Welcome. All. If there is any comment from any other colleagues, okay, we'll send to you the record, and all the panelists will ask them to send their slides if they have. This is help in documentation. I send my slide also to you. we'll work with Abba and Jack and all who volunteer with us to write a report first, then we'll write something, documentation about this meeting, and I'll send to all of you, and please send to all colleagues materials of the next webinars. So to enjoy and to be in the subject, not just general talks, but it will be very, very specific. I finish now. If you have any other point before I close.
Thank you, Dr. Ahmed, for this meeting.
Thank you all, and going forward hand in hand. And bye-bye. Bye-bye, Kathy. Bye-bye all. Bye-bye all.
Thank you,
Bye-bye, Dr.
Professor.
Amal. Bye-bye, Jack.
Bye-bye.
Bye-bye, Jack.
Bye-bye. Thank you.
Bye-bye. Going forward hand in hand. Bye-bye.
Bye-bye.
Thank you, and bye, Prof. Ahmed Elzawawy.
Bye, Abba. You have a lot of things to do.
Yes,
Together,
Prof.
together.
I will. I will going to follow it and get in touch with you for all the series. We will going to make a documentation and make it a document that is publishable and people will benefit from that. I believe that we can do that strongly.
Thank you. Going forward. Thank you, Abba. Thank you. Bye-bye. Bye-bye. Bye-bye.
Thank you.